there really is no safe sun exposure. It's pretty cut and dry, and we know that pretty well, that there is no safe amount of sun exposure. So because any UV radiation, can cause basically damage to the DNA of your cells, right? So, and that could be the mutagenic root of skin cancers.
Welcome to the Exercise is Health podcast, where we're talking about exercise, health, and the interconnectedness of the two. We are your hosts, Charlie
and Julie,
and we will be coming to you every single week from our studio, Muscle Activation Schaumburg. Hey, welcome back, everybody, to the Exercise is Health podcast. We are your hosts, Charlie
and Julie,
and we are coming to you from our studio, Muscle Activation Schaumburg in Schaumburg, Illinois. Now, at Muscle Activation Schaumburg, we believe your health is your most valuable asset. Your health is one of the biggest influencers of the quality and quantity of time that you have. And while there are many aspects of health, our expertise is exercise. Exercise has been proven time and again to not only improve your health, but also increase your longevity and improve your quality of life. But we know that exercise is not the only piece of the puzzle, and that is why we are bringing you a rock star guest today, none other than Dr. Ashish Bhatia. Dr. Ashish Bhatia is a board-certified and fellowship-trained dermatologist and dermatologic surgeon. He is an internationally recognized expert in dermatologic surgery and cosmetic surgery. His expertise includes facial and body aesthetic surgery, skin cancer therapy, Mohs and reconstructive surgery, laser surgery, and skin resurfacing procedures, including scar reduction and revision. Dr. Bhatia has contributed to the advancement of techniques in facial reconstruction, scar revision, fat reduction, and the use of purified neurotoxins and fillers. He has published extensively in journals and textbooks and is a sought-after teacher, speaker, and instructor both nationally and internationally. Through his clinical research, publications, public service initiatives, and the use of innovative technologies for instruction, Dr. Bhatia has made a broad range of intellectual and practical contributions to the fields of dermatology and dermatologic surgery. Dr. Bhatia received his medical degree from Northeastern Ohio University College of Medicine, where he was introduced into the Alpha Omega Alpha National Medical Honor Society and earned awards for both achievement and service. He completed his residency in dermatology at the Medical College of Virginia Hospitals, where he served as chief resident. Subsequently, he completed an intensive fellowship in Mohs surgery, cutaneous oncology, reconstruction, and cosmetic and laser surgery at Skincare Physicians in Boston, Massachusetts, under the direction of the leaders in the field from Boston University, Harvard University, and Yale University School of Medicine. Dr. Bhatia is an associate professor of clinical dermatology at Northwestern University Feinberg School of Medicine. He previously served as the chairman of the Department of Dermatology at DuPage Medical Group. Dr. Bhatia's memberships include American Academy of Dermatology, American Society for Dermatologic Surgery, and the American Society for Laser Medicine and Surgery, the American College of Mohs Surgery, and the American Medical Association. Dr. Bhatia is a co-founder of Oak Dermatology, with locations in Itasca and Joliet. Dr. Bhatia, thank you so much for being here. We're really excited to talk with you.
Well, thank you so much for having me here. I'm very excited to be here.
Absolutely.
After hearing that, I feel like, Charlie, you and I need to work on our bio.
I know, right? That is just
really
awesome.
Work on that.
Or maybe I need to cut mine down.
No, that is so cool. That is so cool. Well, I know that we have a ton of questions for you about, what you do and the specialties of your practice, but tell us more about yourself before we get into that. How did you get into medicine to begin with? And specifically, how did you get into dermatology?
I think medicine was something I always knew that I'd wanted to go into for the science of it and really kind of the aspects of research, science, and really helping people. There's so many ways we can help people, but it was just one of the ways that I thought of. And, there could have been a lot of different pathways, but I really enjoyed this one because, it was funny. My dad actually told me this when I was kind of thinking about different career choices in science. And he said, hey, look, you can dabble in a lot of things. You can't dabble in medicine. So why don't you do that and do that right? And so that's what kind of led me down that path. And then, a lot of things happen in life just from people you meet. And one of the biggest influences for me has been my teachers along the way. And I thought I was going to medical school to be a general surgeon, and along the way I met 1-2 good professors, and they kind of introduced me to dermatology, and I'm really glad they did. They did, because it really is. It's a great field for several reasons, right? I mean, we all have skin. Everybody cares about their skin, and most things on the skin we can detect early and treat too, because it's very accessible. And so for that reason, it's a really cool specialty, because there's that part of it that everybody can relate to. It's hard to relate to liver enzymes,
sure.
But I think everybody can kind of relate to skin and skin problems, and so being able to help people with those is really fun and very rewarding.
That's really neat. Now, when you first started off in the field, what was it about the dermatology field that really drew you in? What was it about your professors, your teachers? Mm-hmm. Because I think we get to your point about everybody can relate to being skin, like I think we all can also relate to having somebody that's been very influential in our life and directing us down a certain path. So what was it about them that shed a light on the beauty of dermatology, practicing dermatology versus general surgery?
Yeah, that's a very interesting question, and I have to kind of think back to like sitting in some of the lectures, and one of the things that really stands out is, unlike all the other specialties in medicine that I was exposed to, and honestly I could have seen myself doing any one of them. I like really enjoyed OB when I did it, every one of them I'm like, okay, I can picture myself doing this. But when I got to dermatology, one, it was something you don't learn much about. It really is kind of a subspecialty, and so there's this huge body of knowledge. If you look at the big textbooks in dermatology, there are these 2-volume textbooks, and they say 2/3 of those things you'll never see in your lifetime. But you still need to know them and be able to diagnose and treat those. And so that's kind of something exciting. It's really kind of a niche where you can really get down, be intellectual, and really learn and understand diseases. The second thing was, it's one of the specialties where you can make most of the diagnosis just by sight.
Oh, cool.
That's cool.
Which is really cool, right? Because everything else we do, and you see it more and more as medicine is evolving, the classic physician that really could, take your pulse and listen and use their senses to make the diagnosis, it's kind of going away. Everything's being replaced by tests. Dermatology is one of those fields where still we can look and help most people out just by looking and listening to the patient and hearing their story, which is fun.
I can really appreciate that, because so my father's a physician and he's been practicing for close to 25 years now, I would say, kind of full time. Let me think, how old is he? No, actually probably closer to 30 years, between 25 and 30 years full time. And to your point, he talks about the process of like actually becoming a doctor. Meaning, you graduate medical school, you go through residency, you go through your fellowship if you have one, and then you're out and you're considered a doctor, but you're still, like, in his opinion, not necessarily a practicing doctor, because if you have to be able to use your senses to get a feel for what's going on and not just so reliant on all the tests. And so he speaks to that. So I can definitely appreciate what you're saying with that. That's really neat. That's really neat.
Your dad's right on with that. I mean, I think that those first 5 years out, you learn more than you really learned. You in med school and residency and stuff, you build the foundation, but you really learn to practice in those first 5 years. I think that's why they call it practicing medicine.
Sure,
right? You're still always practicing. You're always getting better. So
I was going to say, the other thing that I think is really interesting about dermatology that you brushed on is that it's like there's so much that you could know and you'll probably never see 2/3 of it. But I think it's also a field, maybe just in my uneducated opinion, kind of like exercise, where everyone kind of knows about it, and the education to the layperson, like to a consumer out there, is not very good. There's so many skin products and so many skin techniques and ways to prevent this or that, and people probably come see you all the time and you hear what they've been doing to deal with their skin, and you're like, so let's restart from the beginning of how we're going to take care of your skin, and just because the education out there is probably so foggy, it's not very clear, like, what should we do, to take care of our skin, or how to deal with this thing. So I feel like you live in that field similar to exercise, where everyone's getting input on exercise, and it's not very clear about what should be happening or what the professionals are saying about that idea or that concept.
You are absolutely correct. I mean, in that way, it really does relate to like exercise and diet, right? Everybody's got an opinion about it. Everybody knows something about it, but a lot of it's not necessarily based on science, right?
Sure.
A lot of it's just trends and stuff. Same thing with skincare and, how you should take care of your skin. There's so many myths out there. And so it's really nice to be able to sit down with a person and really listen to what they're really thinking and believing, and then helping them actually understand what kind of the facts are, and then letting them build on that, So I think it relates very well to your analogy with exercise and diet. I mean, that's one of the things, right?
One of those things that's over inundated with information, and half of it's not from credentialed people. But tell us about your practice today, and tell us what you guys do. Tell us about how you guys got started. What are common things that you see? Tell us about that.
Yeah. So, one of the other things I love about dermatology is kind of the breadth of the field. So, it's not just, skin checks and acne and warts. It's, and one of my professors told me this. He's like, look, here's a specialty you'll never get bored in, because you can take care of adults, you can take care of children. So we see both sides of it, kind of cradle to grave. We say, we're taking care of patients, and there's the medical dermatology side of it, with real skin diseases. There's the cancer side of it. There's the surgical side of it, and what you hear about a lot more on popular media is the aesthetic side of it, right? So the good thing also about dermatology is that it's relatively speaking, one of the younger specialties. And so there's a lot of research still being done in it. And, so our practice kind of encompasses all of that, from, pediatric to adults, skin cancer surgery, lasers, aesthetic surgery. And then, it's something that myself and my partner in practice, his name's Dr. Jeffrey Sue, we've been practicing together for about 10 years, and we've known each other since fellowship, so about 15 years. We were both passionate about research as well. And so, a lot of the products and drugs, devices that have kind of come to market over the last, 10 years or so, we've been able to have a part in that. And you got to remember that when you see these products hit the market, for everyone that does hit the market, there's 10 or 12 trials that didn't go well. And so you get to learn a lot about what does work, but also what doesn't work.
Yeah. So talk to us more about that aspect, the research. What do you mean, like you've had a part in a lot of the, like you've helped with the development of the products, or what has that part been in the research aspect?
Yeah, so, it started off really working more and doing the clinical trials part of it, right? So, while they've done development of whatever product or device it is, eventually you have to prove that it works, and you have to prove that it's safe. So that's what trials are done for, is safety and efficacy. And so, that goes through there's a formal process in the U.S. and other countries, and here it's regulated by the FDA. And so, we go through and we actually do the clinical trials, so we find patients that would be suitable for. And so you start off doing that, but over time you get more into developing those trials and really figuring out how are you going to show that this is or isn't effective, and really what endpoints are you looking for, and so more and more you get into research, you can do a lot more. And now I spend a lot of time in labs with scientists and looking at things that they're working on, which may have impact on somebody's health or wellness. So now it's really kind of the span of it. So now, in the beginning it was just executing the clinical trials, but now we're actually helping design devices and actually come up with drugs and also cosmetic or aesthetic products too that are used in medicine. So, and it's kind of fun, right? Because there's like, for instance, there's a medicine called Kybella, that you inject into fat, and it dissolves the fat, like in a double chin.
Wow.
And it's really naturally derived because it's deoxycholic acid, and that's what's in our bile. So when we eat fat, that's how we digest it. And so that's how it came about, right?
It's
so,
like a local treatment for
yeah. And it works really well. And so like before that actually got approved, you know, myself and Dr. Sue, we were both using it for over 7 years because we did phase 2 and phase 3 studies. So you really get to know the ins and outs of a medicine and how it works and all that.
So is that how you get your 6-pack? I'm just kidding.
Yeah.
It's like, you're like, oh, we get people wanting 6-packs. No, that's really
awesome.
interesting.
That's
really
your
cool.
domain.
Right. Exactly.
Yeah. Well, I love that you guys are doing that because this is reality, but it's kind of interesting is that every time you work with a patient, they're almost like their own N1 study because you can know, you know, everything about what commonly works and what's worked for other people. But until you have that one individual seeking a solution for something, you know, you don't know exactly what works for them. So for you guys to already have that thought process of, you know, figuring out, you know, a solution here or for that, or what's the background with this, that I feel like that speaks so much because it shows that, you know, you guys are open to these new things and new progressive drugs or treatments or modalities. So that's really cool that you guys are doing that in your practice like all the time.
I think it really benefits our patients because, like you said, you know, to develop a drug, or you know, you have to know the ins and outs of that drug, but you have to know the ins and outs of everything that's comparable too. And so it really forces you to learn those things where, like you said, every patient is an N of one. You know, they're their own person, and one thing that might work well for you may not work well for you. And so by knowing all those ins and outs of all the other options, therapeutic options, you can help pick the best one for the patient. Or even that sometimes you can't. Something you just don't know it until you try it. And so you're able to recognize, wow, this isn't working as well as, you know, the trials did, or my experience did, right? So, and so then you know all the other options, and so that's what makes it fun because you can really engage with the patient and customize therapies for that patient.
Very
Probably
cool.
much like you guys do, right?
No, absolutely. That's awesome.
Yeah.
That's really neat. So going through your bio and then looking at your website, a number of times this idea of the Mohs surgery came up. So talk to us more about that, because it's a surgery for skin cancer, correct?
That is correct.
Okay, yeah. So like how does that work? And how is that different than kind of other skin cancer treatments or procedures?
Sure. So skin cancers, you know, generally, when it comes to the surgical treatment of skin cancers, the ones that you wouldn't take care of with a topical or whatnot, traditionally the way skin cancers were removed by surgeons, by dermatologists, was that you just take this arbitrary type of safety margin around the tumor. So, you know, you see the little spot, you draw a 0.5 centimeter ring around it of safety margin, and you knew that you got a 90% cure rate if you remove that. And it's all based on statistics, right? So that's fine and dandy, but you know, if you're working on somebody's face for the skin cancer near the eye or the nose or the lip, you don't want to be taking out any extra skin than you need to. And so, you know, Mohs surgery was actually developed by a gentleman, physician. He was a surgeon up at University of Madison in Wisconsin, named Frederick Mohs. So it's not an acronym; it's actually a guy's last name. So, you know, Fred Mohs came up with this technique, and you know, it was very different when he first came up with it, but it eventually developed. And so, it's a way to remove skin cancers with the highest cure rate possible.
Wow!
But by taking out as little extra skin as possible. So we call it a tissue sparing technique. So you leave as much healthy skin intact as possible, but you still get a very high cure rate.
Wow.
So you're not relying on statistics to just like take out arbitrary amounts of tissue.
Take this chunk out.
Yeah, exactly.
Get all the skin cancer out of there. Yeah.
Because if it's on your back, you know, it's okay. You know, if you removed a little bit extra, nobody's going to know, and you'll be able to close it. But it becomes a lot more critical on the face, ears, scalp, hands, fingers, toes.
For sure. That's really neat. So how are you able to detect with such a high rate of success kind of exactly where the cancer is? Do you have to use some kind of dyes or other things to highlight the tumors? Or the cancerous cells, I should say?
That's a very good question. So, you know, at first we use our senses, you know, and just like traditional classical medicine, you want to look and feel and get an idea of how large you think that tumor is, right? So how far it visibly extends. That's number one, right? So we kind of dot out what we see. And then the second thing we actually do, and something that patients don't often see, but I try to explain to patients every time just so they have an understanding, because they always ask, hey, yeah, you can kind of clinically see how wide and tall that is, but you don't know how deep that is. How deep? Why? Why are you going as deep as you are? Well, the second thing we do is after we draw out the clinical extent that we can see is we numb the area up, and we actually use a little curette, and a curette is like the world's tiniest melon baller. And it turns out that the skin cancer cells are softer than normal tissue, and they don't hold together to each other like normal tissue does. And so you can scoop them out kind of like the soft spot in a piece of fruit. And when you hit normal fruit or normal tissue, you can't scoop anymore. And so the second way we do it is we really by feel.
Wow, yeah.
Yep. So you kind of scoop out everything that is soft.
Sure.
And now you can pretty accurately take 1 millimeter, 2 millimeters, whatever you want around that defect that's been created. And now you're only testing that small area. So
yeah, that's cool.
Yeah. So
that's really cool.
You can be very precise. But I think that second step's pretty crucial to understand, because that kind of defines the depth and the bottom surface of where that tumor is going to.
Oh, interesting. Very interesting. Yeah.
Well, as we talk about this Mohs surgery, I know I had heard about it because my mom was in the dermatology field a little bit, working with different doctors. But can you tell us a little bit more about skin cancer? Like, what is skin cancer? I think we all think of it as like it's a mole that changes size or color, and then I go to the dermatologist. And I think that's the extent of what we know what it is. So can you tell us a little more about what it is? Are there, different ways that people get skin cancer? And what should people do about it if they feel like they might have something like skin cancer?
Well, let's take a step back and let's talk about cancers in general, right? So, cancers are really cells that have kind of gone bad or gone rogue, right? That they're replicating in kind of an uncontrolled pace. So the little stop button that they internally have telling them when to divide, for one reason or another, has that malfunctioned. And so now they're replicating faster than they should. And so all cancers are really defined by what cell line they originate from. So liver cancer comes from the liver. It might metastasize and end up in the bone or other places, but it comes from the liver. So skin cancers are all derived from one of the elements of the skin. So the one that we hear about the most, but is really probably one of the least common, is melanoma, right? So, there's Melanoma Monday, and May is Melanoma Awareness Month. And so, the reason we hear about it more is because it's one of the most deadly skin cancers. And the reason it's called melanoma is it actually comes from the melanocytes. And melanocytes are just the cells that are in the skin that actually make pigment. And so, that's where we get our melanin from. And that, so depending on the quality of your melanin, the density of your melanin, it defines what skin color you really are. But when those cells go bad, not the pigment cells, but the cells that make the pigment, the melanocytes, when they start reproducing or replicating, I should say, at a uncontrollable rate, then you have a melanoma. So like I said, that's the least common of the three most common.
Even though it's the most deadly.
But it is the most
deadly.
And
most people know about it the most.
And most people
because I've heard of that one, melanoma.
Definitely.
Yeah.
So like if you have more melanocytes, are you more prone to getting a melanoma?
Interestingly, no.
Wow.
Yeah. So
interesting indeed.
Yep. It's actually
is it the opposite?
Opposite, right? So because something has to damage those melanocytes to actually cause the problem. And one of the things melanocytes are very good at is protecting themselves from the major source of damage, which is UV radiation, right? Sun, is where we get most of our UV radiation. And so melanocytes, that's, if you think about it, especially if you have fairer skin, first time you go out, you might burn more easily, and then you will get a little darker, right? Well, that darkness is the melanocytes dumping out and actually putting melanin kind of above themselves like an umbrella to try to protect themselves from the damage. So, I'm giving these things life and a personality.
No,
but,
it's
but,
Sure, yeah,
but
no,
it's
no.
if you really think about it, that's what happens, and that's really what a sunburn is. It's a protection mechanism, and so but people that have lots of melanocytes are heavily and are heavily pigmented, they naturally have a lot of melanin there that's protecting their melanocytes, and so you just don't, even by being exposed to UV radiation, you're less likely to get actually melanoma, which is kind of interesting, right?
So Mr. SPF 100 Charlie Cates, he would be a prone candidate for potentially developing a melanoma. A melanoma versus someone with a much darker pigment than him. Is that correct? I see.
Yeah.
Interesting.
Now I'll add a caveat to that. There's two things really that cause melanoma. So one is that the UV exposure, but the other is actually your genetic predisposition to it.
Okay.
So there is a family inheritance pattern, and so there are people that are more susceptible to it. And there's a recent study that was just published that showed that people that actually just have more moles in general definitely have a higher risk of melanoma.
Okay.
And so so part of it's genetic and part of it's environmental exposure. So, and the genetics really determines two things, right? One is that you'll have moles that might go bad or have a lot of moles, and two is your skin color and your fairness, and so how susceptible you are to UV radiation. So it all kind of ties in, there's always that debate about, is this genetic or is this an environmental thing that's causing the issue? It's really both. It's a combination. So,
interesting.
Yeah.
You mentioned, that was an interesting thing you said. You said you have someone that might have more moles that go bad. So are moles like the invitation for like a melanoma to appear, or why is it always associated with a mole, or is it always associated with a mole?
Good question. So, and it's something people have debated for a long time, but now we know that, probably about 60% of melanomas actually come from a new mole that develops, not an existing mole that went bad.
Okay.
But, still almost half the time it is a mole that goes bad, right? Or a little less than half the time. So it can go both ways, but like an independent risk factor, and a lot of this is just based on statistics and research, is, you have more than 50 or 100 moles, then you're a little more likely, and it kind of makes sense. You have more moles, and moles can go bad, and so you might, you have a slightly higher risk of skin cancer. So,
interesting.
Yeah.
So when you say like moles going bad, what does that mean? Because when I think of like going bad, I think of like, fruit in the fridge going bad. But like, what do you mean by like moles going bad?
So by moles going bad, we were talking about, it's usually a cell line that starts reproducing. And so by going bad, I'm saying that they've kind of mutated in a way where they're reproducing or replicating uncontrollably. And so, and if you look at a normal mole, even under the microscope, so a big part of dermatology is actually dermatopathology, where we actually look at the lesions under the microscope. And it's really a nice part of the field, because then you can understand things really at their microstructural level. And if you look at moles, normal moles, they're really just a cluster of melanocytes. So they look like little grapes, like a cluster of melanocytes. So, and what we look for when we're looking for melanomas is a lot of little things, a lot of subtle details. Melanomas are by far one of the hardest things to diagnose underneath the microscope. So it really does take an expert to do that. But you look for the cells looking abnormal, where they look more like cancerous cells than normal cells. But then sometimes you look for inflammation, the body's response to cancer cells being present. So, but at any rate, they're even a normal mole just looks like this little cluster of melanocytes. So the normal melanocytes are pretty evenly kind of distributed through our skin, and that's why most of our skin tone is fairly even.
Okay.
But then where you have moles, you have this large cluster of melanocytes, and they're producing pigment, and so you can see the pigment underneath the microscope too.
Interesting.
That's so cool. I didn't know that.
Yeah.
What's the difference between moles and freckles?
Good question. So,
I'm curious.
So, a mole, like I said before, it's a cluster of melanocytes that are kind of growing there together in a little nest. And then they make pigment, and then that's why you can see them on the skin, because you really see the pigment. Sometimes you see, a lot of people have just like pink moles or skin-colored moles. They're just raised bumps, right?
Sure.
So those are ones that just aren't producing pigment.
Gotcha.
And if they produce pigment, which, most of them do over time, usually the natural evolution of a mole is, uncolored and flat. It exists, but you can't see it. Gets raised or it gets pigmented. And then if you live long enough, all your moles actually kind of depigment and go away.
Oh, interesting.
Yeah, so and that, at least that's what I'm told.
Yeah,
that's
sure.
what I've learned over the years.
I hope I never lose my beauty mark on my face. I love it.
So in contrast to that, the other question is, and what are freckles, right? And so, the medical term for freckles is ephyllid, EPH. Is what it starts with, ephyllid.
Sure.
So
Ephyllid.
ephyllid. So ephylids, and so those are also collections of melanocytes, but really more a collection of pigment, and so it's really that there's just more pigment that's been laid down.
Okay.
And so when you look at that kind of under the microscope, it's just a very superficial pigment that you're seeing. You're not seeing this nest of
Gotcha.
melanocytes underneath, and then. There's another thing too called sunspots, right?
Oh, sure, yeah.
Age
yeah,
spots,
yeah.
right? And so those are very similar too. They're basically, you do see the melanocytes kind of at the surface, and then you see all these pigment around them, and they're called lentigos or lentigines. And so moles or nevi and freckles, you've really been kind of born with those.
Okay.
Sunspots are ones that are more from chronic sun exposure, and that's why you see them more in sun-exposed areas. You can see it on the back of the hands or on the face. So, yeah.
So we have melanoma, which is the least common, most deadly. Most people know about them.
Yep.
What are the more common ones that are less deadly?
Yeah, so let's go to the most common one, right, which is basal cell carcinoma. So basal cell carcinomas, not only are they the most common skin cancer, they're the most common cancers in humans, period.
Oh.
Wow.
Yeah, there's over 1 million cases a year in the U.S.
Dang.
And so they're extremely common. And they're mostly in sun-exposed areas, mostly in skin types that are fair. Like, we don't see them much in the very dark skin types. And that's really because they're really caused by, a lot of it's really caused by sun exposure and UV radiation. So that's why it makes sense, right? They mostly occur in areas that are sun-exposed. And they're extremely common. They say, if you live long enough, you'll probably get one, and if you had any sun exposure.
Sure.
So
Okay.
so we see a lot of those, and like I said, the sun-exposed areas are mostly the face, so nose, ears. I tell people things that stick out of your head; those are the ones.
Top of the ears, right?
Yeah, top of the ears. Yeah, we see them, and then around the nose we see them, and then we also see them, on the cheeks and chin and eyelids. So they can kind of occur in any sun-exposed area.
Anything that pokes out of you
Yeah,
gets
Anything
exposed.
that sticks out of your head. But yeah, so we see those a lot. You see them a little less often on the hands and whatnot, but you definitely see a lot of those on the head and neck area and the scalp too.
Sure.
Yeah.
Sure.
Cool.
And then what is the other way?
The other
Oh,
skin
the
cancer?
other one, yeah.
The other skin cancer is squamous cell carcinoma, and that one kind of falls in between. There's usually about roughly 200,000 cases a year in the U.S., and that's also derived from one of the layers of the skin where the cells have kind of gone bad, right? So basal cell cancers are caused by basal cells, which are the bottom layer of the epidermis. So, we think of the skin really in two sections, the epidermis, which is the top layer, and the dermis, which is really kind of the thickness of the skin. So if you think of it like a leather belt, right? The part that you can scrape off on the top, that's your epidermis. That's about how thick it is. It's really fairly thin. And then, the thickness of the belt,
Sure.
the hard part of the belt, what gives it all of its tensile strength is all the collagen there. And so that's the dermis.
Cool.
And the dermis is really kind of the living part of the skin. Most of the epidermis is dead already,
Sure.
and then it peels off. And so the base of the epidermis is made of basal cells, and that when those cells go bad, then you get basal cell carcinoma.
Okay.
So what are some signs or symptoms that might present themselves if somebody is developing skin cancer? Like, is there anything that somebody might be able to detect at home that would tell them, hey, I need to go see Dr. Bhatia?
Yeah. So, one of the things with skin cancers is that all skin cancers are curable if you detect them early. And so you bring up a really good point. You should be able to recognize that at least something's not going right. And it's a little different whether you look at melanoma type skin cancers or non-melanoma type skin cancers. So, melanoma type skin cancers, there's kind of a easy mnemonic that we use to remember, what are some of the signs of a mole going bad or a spot that's there that's going bad. And it's A, B, C, D, E. A stands for asymmetry. Okay. So if you look at the mole and you draw a line through it and you look at one half and the other half, they should look symmetrical. If they don't, then there might be a chance that, it might be going bad. B is the borders. Are the borders distinct so you can tell where the mole ends and the normal skin around it begins? And it should be that way, but if it's starting to blend in or the borders are irregular, that could be another sign. C is color. If there's more than 2 colors there, then sometimes that can be a sign of a mole going bad. And then D is diameter, and that's kind of a rule of thumb, about 6 millimeters, which is about the size of a pencil eraser, the back of the pencil. Okay. So usually, if it's larger than that, and it's something new that's kind of grown to that size, you should probably tell your dermatologist about that. Okay. And then E is evolution. And that's the patient's story. Like, they're sure that wasn't there, or it's growing, or it's changing, or they're having any symptoms like bleeding, itching, pain. Those are things that we look at. Now, none of those have to be there to be a skin cancer or a melanoma, but usually one of those things is present from the A through the E. Okay. And a lot of times, especially people that have lots of moles, the only way we know is that it changed and the patient detected that it changed. So most of these skin cancers are actually caught by the patient, not the doctor. And so that's why it's very important to do a self-skin exam. Yeah. There's a website. It's called checkyourskin.org. Okay. And it kind of takes you through how to do a self-skin exam. There's also the American Society of Dermatologic Surgery, which is based here too in Chicagoland, and they also have some resources on their website about how to do a self-skin exam. So it's really just like self breast exams are important for early detection. Same thing for skin cancer. Self examinations is important, especially if you're prone to it or if you've had a lot of risk factors for skin cancer. Sure. And risk factors are something we can probably talk about as well.
Yeah, absolutely. That's actually my next question. So that's perfect.
So the risk factors, one is a genetic predisposition to it, so a family history of skin cancers. 2 is really a history of sunburns. So even one blistering sunburn greatly increases your chance of skin cancer. And then the third is really if there's some genetic syndromes and much more rare type things where people get more skin cancers. But if you have a family history, you've had a lot of sunburns, or if you've had a previous skin cancer, you're at higher risk. So you should be checking yourself and really checking yourself about once a month. So we tell people pick the first day of the month and just do it. Okay. Now, if you have a lot of moles, that becomes tricky because how do you know something's changing? And so, one of the tips I give to my patients is to actually take pictures. Now cell phones have such great cameras, right? Sure. The only factor that's usually kind of missing is the lighting. And you guys know you work in studios and stuff, so lighting's really crucial. So I tell patients to go ahead and get in good lighting and go ahead and take some pictures of your arms, back, chest, legs, face. And use those as your baseline. And so every month when you do your self-skin exam, compare yourself to those pictures. Okay. And that way, if you can't quite remember if that was there, you can always look at that picture. And you get good at learning your own topography then.
Sure. Yeah. I was going to say, the people that are really prone, like you said, they have a lot of moles. That's a lot to keep track of.
It's a lot to keep track of.
It's not just one mole that you're like, oh, this one mole didn't change or did change, but now I've got 50, to keep track of.
Yeah. And then let's talk a little bit about the non-melanoma skin cancers and how you detect those, because it's not the ABCDs for that.
Oh, so the the A through E
is for melanoma.
Is only for melanoma. Okay.
Right, because melanomas are the ones that produce pigment, and so it's really the ones that are pigmented. And that's not to say some of the non-melanomas don't produce pigment, but you don't catch them based on their pigment. You really catch them on the fact that it's a sore usually that never goes away. And so it partially heals and then it opens up again. So those are signs of a basal or squamous cell. The other, with basal cells, a lot of times they can look one of three ways. They can, like I just said, can be a sore that never heals completely. Sometimes they can just look like a pearly little bump. It has kind of like a pearly appearance to it. And if you look really closely, it even has like little blood vessels kind of going through it. So that's a very common appearance for a basal cell, like on the tip of the nose or on the cheek. You can see those. And then third is kind of like a rough erosion or a rough red patch, and that could be either a basal cell or a squamous cell. So they can look a bunch of different ways. So it is important that if you think you have something that's unusual, that you get in and see a dermatologist, because to a layperson they can all kind of blend in, and it makes it very difficult to tell.
And those seem like, I mean, let's be honest. If I saw a white pearly thing on my nose, I would work to like try to extract it myself, probably for like months. Or if I saw like a red dry spot, I'd probably lotion that thing for months and months and months and not think anything of it. So it's interesting you said that, because I would have never known. Do you think a lot of people do that? Like, do you think they would treat it the way I do, or?
In fact, they do. They treat it exactly the way you do until they've had one, and then they know, right? So, because how would you know otherwise? And unless you listen to your podcast or something, if you most people just don't. They're not educated on this, and it's understandable. You see a bump, you try to pop it or pick it off. That's what 99% of people do, right? So it's the natural response.
So you talked about the different risk factors, one being genetics, another being sunburns that have blistered in the past. Is there any amount of like quote unquote safe sun, meaning that somebody could have exposed skin to the sun and it would be safe up to a certain limit or during certain times of day? Is there any recommendation as far as that, or is it something where, hey, if you're out in the sun, you either need to have your skin covered with clothing or some kind of protective barrier?
So there really is no safe sun exposure. It's pretty cut and dry, and we know that pretty well, that there is no safe amount of sun exposure. So because any UV radiation can cause basically a damage to the DNA of your cells, right? So, and that could be the mutagenic root of a skin cancer. So unfortunately there is no safe amount of sun exposure. So what we recommend is to always actually wear a sunscreen. And so, there's actually been studies that have shown if you're good about putting on sunscreen on your face, ears, neck, on a daily basis, you can actually reverse some of the sun damage you've had.
Interesting.
Yeah, because like most other systems in the body, the skin has its own little immune and surveillance system. Right? So there's these cells that wander around the skin and they look for damage to the DNA. And they look for cells going bad and they destroy them. Interestingly, those cells are completely deactivated by UV light.
Really?
Yeah. And so if you're getting constant UV exposure, those cells can't do the job that they're meant to do. And they can't actually heal your skin. And so just by wearing sunscreen on a regular basis on exposed areas, you can actually help those cells to do their job, because they can thrive and they can walk around, and they're the guards of your skin.
That's so great.
Now, do you recommend with the daily use of sunscreen to get it in like a face lotion form, or like to actually use a completely separate sunscreen? I don't know, what one of the issues that I think is just a personal issue for me that I have with sunscreen is I hate the scent of it. So to like always have that on and feel like it's always on my skin, it makes me just feel really uncomfortable. So I'm wondering if you have any suggestions. So
my answer to what's the best sunscreen to use is the one I can get you to use. And for some people it's their moisturizer that has sunscreen in the morning. Some people, they break out really easily, so anything greasy, they're not gonna be able to tolerate it. Or there's a lot of people that have skin like yours too, or just don't like the feeling of having something on there. So you just have to find something that's going to work for you. For instance, for most men, the best I can usually do is to get them to use something that's not going to get their hands greasy. And so I usually get them to use powdered sunscreen.
Oh, interesting.
Yeah, and in the beginning I got a lot of resistance on that. So most of the powdered sunscreens, they come in a little stick with a brush on the end and have a cap on it. And you just take the cap off, you brush it on, and you put the cap back on.
We gotta get some of that.
Yeah.
Well, I was gonna say, with women, it's in my makeup. So I'm putting it on all the time, all over my neck and all the way up to my hairline, and I love it way more than like the sunscreen.
Yeah, for sure. And that's about all I can use too. Like I don't like the greasy feeling, and I break out easily, and so I use the powdered sunscreen every morning. You know, I just take the cap off, and like, as you can imagine, some of our most frequent flyers for skin cancers are golfers and pilots. You know, because they're exposed for every 1,000 feet you go up in the air, you get 4% more UV radiation. And so, you know, it's been shown they have almost double the rate of skin cancers other people do, right? So, but they can't afford to get their hands greasy. You know, they got controls to deal with.
Oh my gosh, yeah.
Golfers, same thing. You don't want that club flying, you know. So I'm not going to be able to get them to put on a lotion regularly. And so in the beginning, the golfers, the pilots, they all scoffed. They're like, I'm not putting on powdered sunscreen. That's like makeup. But now you go to any golf course, you see guys putting it on all the time.
Interesting.
Yeah.
Okay.
Wow, that's awesome. I've never even heard of that. We'll have to get you some of that,
Yeah.
Jerry.
Definitely.
Yeah, the one I like, it's called Color Science.
Okay.
But I mean, there's others out there as well. So you know, find one you like. The other thing I like about them is they don't have a lot of chemicals in them. They're mostly physical blockers, meaning that they're blocking the UV radiation by physical elements. In this case, is titanium and zinc.
Okay.
Yeah. So those are they're physical. They stay on top of your skin, and and you're much less likely to react, because some of the sunscreens people get allergic reactions to too.
Sure.
The chemical sunscreen. So one of the benefits of using one of the physical ones is that it just sits on top of the skin and it's pretty inert.
Well, I know last year when we went to Jamaica for our honeymoon, we had to go and get sunblock, and Julie would only let us get sunblock that had the titanium or the zinc as the main ingredients. And we came back. I remember my clients asking me, like, "Did you go out in the sun at all?" I'm like, I was out every day, but I used to like, "You didn't get tan." I'm like, "But I didn't get burned," and so it worked great.
Yeah,
well, and Charlie, as anyone that knows Charlie, and you're sitting here looking at his skin, you know he's like one of the most prone lobster kind of people. It's like you stick him out in the sun, and if he's unexpectedly out there for an hour and he didn't know he was going to be out there, he's burnt. And it's one thing you hate too. So it's like even worse, because then you're all distraught about it. But it's uncomfortable to be burnt. What about the clothing that has SPF in it? Like, because I've seen clothing that has SPF, but then I always think, well, is my shirt then not like protecting me from the sun if it's not labeled as SPF 50 or whatever? Yeah.
So clothing has its own kind of rating system. It's called UPF. So it's a little different. And now there's a lot of brands that make sun protective clothing, right? You even see it for kids, you know, when they're at the swimming pool, like there's long sleeve clothing to be swimming in now. And it's because it either has a chemical or some kind of chemical treatment that blocks UV light, or it's such a tight knit that it blocks UV light. Okay. So, you know, if you look at your regular clothing, you hold it up to the light, you can see light coming through, even a little bit, it's not going to protect you. So it's important that, you know, if you really want UV protection, then you actually get clothes that block it, and so that have the UPF, and they do work, and they work pretty well. You know, the caution with that is that, you know, it does wear out after time, just like sunscreen. I mean, sunscreen, whether it's a physical blocker or a chemical, it can only take so many hits of photons hitting it, and then it breaks down. And so, you know, it's really not enough to put just sunscreen on in the morning. You really have to reapply it, especially if you're going to be outdoors. And you know that. You know, you don't have to reapply, and then you'll get burned. So clothing, too, it wears out, and some people don't recognize that. And so, you know, for about 20, 25 washes, it's usually pretty good. Okay. But you do want to replace it. But, yeah, sun protective clothing is good, and it's nice because it's another easy thing you can do and wear. And now a lot of it's very light and very well vented too, so you don't feel all hot and sticky in it.
So you probably get this a lot, but I know that I've heard two parts of the story, right? Like, you need to protect your skin because then you're less prone to developing a skin cancer. But then there's this other group of people that are like, but what about the natural vitamin D? Sure. Don't we need vitamin D? And it's the best way to get it from the sun. Yeah. Can you talk to us a little bit about that? Does always protecting your skin make people vitamin D deficient? Or how can we get around that in terms of being like keeping our risk of skin cancer low, but also making sure we're getting sufficient vitamin D?
Right. So that is a constant debate in the scientific community, and people really strongly believe one way or the other. Usually it's kind of polarizing, right? But the reality of it is, I mean, the facts that we do know is, number one, we talked about it before, there's no safe sun exposure, right? So yeah, if you're counting on sun exposure to make vitamin D, then your risk is that you're increasing your risk of skin cancer. The other fact that we do know is that vitamin D can be replaced other ways through good diet or supplements, right? So really, if you have any risk factors for skin cancer, you don't want to risk it, then avoid it. There's a lot of populations that really don't get skin cancer as much, and so they rely more on vitamin D from sun exposure, but you don't need to. That's the bottom line.
Gotcha.
Is that you can just supplement that, or if you have a good healthy diet, a lot of it. And people should get their vitamin D levels checked. If they're worried about that they don't get enough exposure, or their diet or supplements don't cover it, because vitamin D deficiency is a real issue. So I don't want to make light of it that, like my organ is better than, your body's health, but so, if you are deficient, then definitely get it supplemented. And I usually recommend patients that if I'm recommending they're using sunscreen regularly and avoiding the sun, because it's not only sun protection, but it's also sun avoidance, right? Like not going out between 10 and 2 when the sun is at its highest and all that type of stuff. So, these are all important little tips, but if you're really good about sun protection, sure, you could definitely be deficient in vitamin D. And I do recommend those patients get their level checked and then supplement. Because vitamin D deficiency causes real issues. So
Yeah.
It's a really, really good and interesting question.
I feel like every field has their majorly polarized thing, which maybe that's one of the ones in dermatology world today.
Yeah, for sure.
Now, you brought up two different types of kind of protection or blocking from the sun. You said a physical block and a chemical block. What's the difference between them? Because I guess I always figured that sunscreen was more on the chemical side, and then now hearing the zinc and the titanium is actually a physical block. So what's the difference between the two?
Yeah, so zinc oxide and titanium dioxide, they're minerals, right? So you're basically laying minerals on the surface of the skin, and the UV radiation is actually hitting those, and they're absorbing that UV radiation so it doesn't get to your skin. When you're using a chemical sunscreen, then you apply the chemical sunscreen, and the reaction actually takes place on your skin, which creates a complex that will absorb those photons from the sun, or UV radiation in this case. And so the good thing about physical sunscreens is they work instantly. You put it on, you got the protection.
It's on.
The regular sunscreens, if you kind of listen to the instructions around them, they always tell you to put it on about 10, 20 minutes before you go outside, because it takes a while. There's a chemical reaction that needs to happen, and then it can absorb and take those hits for you instead of your skin taking the hits from the UV radiation. So
interesting.
And we all know that we put on sunscreen while we're already laying out by the pool.
Exactly.
So.
That's how it usually goes down.
Exactly.
Yeah. So if someone thinks they have a skin cancer, what do they do?
So if you're concerned at all about a mole or a spot that's not healing, you should go see a dermatologist. I mean, that's really kind of your first step there, because most of the time a dermatologist will be able to look at it and tell you, yes, this probably is, or this is unlikely, it's an age spot or XYZ. So, and that's, like I told you, that's one of the cool things about dermatology. We can look at things and most of the time make the diagnosis. And if we're unsure or we're very suspicious, then we do a biopsy, which is usually really simple. It's a little in-office procedure. We'll just use a little local anesthetic to numb the area up and take a really small piece of it and send it off to a lab. And that'll give us an accurate diagnosis. So very easy to take care of, and it's something, it would just be kind of part of your visit, right? It's not like you have to schedule a separate appointment. You go in, you get it checked. Most of the time, the dermatologist will just biopsy it right then.
Nice.
And it's important to do that, because if there is a high suspicion that it's a skin cancer, we know we can cure it 100% if we catch it early, and so we want to get right on that.
Sure.
Sure. And then is the only treatment option, we already talked about the Mohs surgery, is that usually the treatment option, or are there other options if it is a form of the 3 different skin cancers?
Sure. So, Mohs surgery is actually reserved for very specific situations. So, because Mohs surgery is fairly labor and resource intensive. You come into the office. The typical day for a patient that's having Mohs surgery is you come in early. We identify the area, we numb it, we do the little curettage, and then we remove the tissue. But once we remove the tissue, then we put a bandage on you, and that tissue has to go to a lab that's right there in the office. And there's a special tech there, a technician that will take that tissue and actually process it in a way and stain it in a way where by taking a single slice of tissue off of it and looking at it under the microscope, we can examine 360 degrees of the margin, because that's how we can reliably tell you that, yes, we got it all or not.
I see.
And it's by looking at all the margins. So that process can take anywhere from a half an hour to 2 or 3 hours, depending on how long it takes to make those slides and for me to look at them. And another definition in Mohs surgery is the surgeon has to be the pathologist. So the person that's removing the tissue actually has to look at it under the microscope, because only they really know how they removed it.
Sure.
And they understand the orientation. So you can imagine, and then if it's positive, you can see exactly where it's positive. That's mapped on the patient's skin, and you go back and you only take a tiny bit more from that area. So it's very precise, but it's very tedious and labor intensive. And so you don't want to use that willy-nilly. So we mostly, there's very strict guidelines on what kind of tumors you can use it for and what locations. So like I said, mostly cosmetic sensitive areas, fingers, toes, genitals, all those places where you don't want to lose any extra skin. Those are the areas we use it for. For a simple skin cancer kind of on the arm or leg, it's usually just excised, where we draw a little margin, safety margin, and take it out, usually in a little football shape or an ellipse. And that way, when you take it out that way, you can just pull it together and close it in a nice straight line.
Nice.
So those are the two main ways surgically that skin cancers are removed. There's been some good studies with basal cell, the type of skin cancer that doesn't spread anywhere generally or kill anybody, that you can remove them more destructively. And so where you just destroy the tissue, and you can do a lot of different ways. You can curette it all out. You can use a laser. Now more and more lasers are being used, but it's really only for certain types of basal cells. So, when you think about basal cells, they're the most common cancers in humans, but I think there's 20 different subtypes of basal cells. There's superficial kinds, there's infiltrative kinds that have kind of fingers that go downwards. Nodular is the most common, where it kind of grows like a ball. And so if you have a superficial type of basal cell, then you have a lot of options that you can do from the surface. But if there's any chance that we might destroy the surface of it and leave the bottom part behind, which is in the more aggressive ones like infiltrative or morphiiform basal cells, then it's better to just cut it out and remove it all. So
make sure you get everything.
Make sure you get everything, because a topical cream, even they make chemotherapy type creams, right? But if you just take care of the top and some gets left behind, then it'll grow for a long time underneath, and then when you have to deal with it again, it's huge and it's underneath
it's almost
the
like
surface.
hiding for a while and growing.
Exactly.
Dang.
And so if there's superficial types, then we have other options too.
Okay.
Yeah.
So Dr. Bhatia, for our listeners, if they're wanting to make sure that their skin stays protected or minimize their risk of skin cancer, it sounds like, to kind of recap some of your main points. One, do a self skin check at least once a month, kind of first of the month, take pictures, look to see for changes. Secondly, go schedule with a dermatologist to get yourself checked out. Third, make sure that you're wearing some kind of sunblock, whether it's physical or chemical, whether it's a lotion or a powder or some kind of clothing. Is there anything else that you definitely recommend people doing?
Well, you should look at the type of sunscreen you're getting. So besides determining whether it's just physical or chemical, and there's combination ones too that have both, the other thing you want to do is make sure it blocks UVA and UVB. Okay. So that's the other thing you're looking for. And then people always ask, what's SPF should I get? Should I get 100?
Good point.
Yeah. So and the answer is, what we recommend is 30 or better. Okay. Because it's a logarithmic scale, so you don't get that much more protection as you go up. It's between a 30 and a 45, it's about 1.5, 2% more protection. So it's not that much, But you'll notice that the cost isn't.
You pay about double.
Yeah, you pay a lot more. And so I'd rather have somebody wear a 30 and make sure they reapply it every hour or an hour and a half, rather than have a really expensive one and then feel like they're going to be protected all day. which is completely false.
Okay.
So it's better to, frequent reapplication is really important.
Good to know.
The other thing that's important too, that kind of, when I tell people to take pictures, you don't take pictures every time. You only take them just at your baseline. So you're always comparing your current skin to that baseline. So the only time you have to take pictures is just the first time. And I think people are like, I don't have time to take pictures every time. There's no need to.
Okay.
Yeah.
Just the first time.
Just so you have a baseline, so you know where you're at.
Well, even if something was growing over a course of a month, you might not notice it. But if you compared like 4 months down the road to 4 months ago, I don't know if things develop that quickly, but you might be able to see the difference a lot more.
Absolutely.
That's a good point.
Yeah.
I'm glad you added those two things.
Yeah, that's awesome. Now, Dr. Bhatia, you've been talking to us a lot about kind of what our listeners can do to help improve the health of their skin, but I'm curious, what things do you do for your own health and well-being?
Interesting question. Yeah, probing the doctor. All right. So I like that. Well, I keep it very simple, and I think I'm like most guys, we're not going to spend a lot of time doing things for our skin, right? So, but the two things I always do, and I have been doing for a long time, one is getting a sunscreen on in the morning. And like I told you, I use the powdered type because it doesn't break me out, doesn't get my hands greasy. I keep one in the car, I keep one in my bag.
Nice.
In my golf bag, I have one in a Ziploc bag with a clean, dry washcloth.
Oh, perfect.
And so that way, every third hole, I just wipe the sweat off of my face and then put more sunscreen on.
Nice.
So, anything I can make routine, I'm more likely to do.
For sure.
And so those are the things I like to do. I like to have the sunscreen in all the right places. And, I like to think every third hole I'm going to put it on, so that way I'm fairly regular about it. The other thing I do use is a retinoid. So a retinoid is basically one of the vitamin A derived creams. And there's prescription versions of it, which are like Retin-A that you might have heard of. And then there's also over-the-counter versions of it, like the retinols.
Okay.
And, they're one of the things that have really been shown to, help improve the fine lines, wrinkles, and overall, the aging of the skin, because they keep collagen kind of growing there. And so I do put on a retinol or a retinoid at night, every night, and I encourage all my patients to do it. Anybody that's concerned about aging of their skin, it's one of the few things that we know has been proven to help. There's so many lotions and potions out there. You can spend, tons of money. I mean, there was an article, if you look in social media, that some dermatologist put on, and she calculated out how much she spends on her skin every year, and it's some $11,000 or something.
Wow.
I mean, that includes, then when you dive into it a little more, it's not just on topical products, it's on her facials and this and that and all that. But still, you can, just at the cosmetic counter at the mall, you can spend a boatload of money, and patients do, and it's kind of one of the more fun things I like is when they come in with that Ziploc bag full of 25 products, and they're like, this is what I'm using. And, you're just kind of looking at it, and they're like, all right, we'll dissect this. And so, but yeah, those are kind of my essentials is I make sure sunscreen, I think, is really important, preventative, and then a retinol, I think, is one of the basics that pretty much everybody should be using.
Awesome.
Retinols can sometimes be a little irritating, so some people can't tolerate them. And so what you really want to do in that case is start slow.
Okay.
Maybe only use it once a week, and then your skin usually gets used to it.
Gotcha.
But yeah, those are my kind of essentials.
Awesome.
Along with diet, exercise, right?
I love it.
Yeah.
I love it. So Dr. Bhatia, let's say somebody's listening to this podcast and they feel like, I need to get in touch with you, your staff. How can people connect with you? How can people learn more about you? How can people learn more about your clinic and your practice?
Sure, yeah. Is essential nowadays. You have to kind of get yourself out there a little bit, and I do like making ourselves accessible, because a fun part of what we do is educate, right? Just like you guys do with this podcast. And so, I wasn't ever a social media person, but now we're on Instagram. Nice. So my Instagram is Bhatia Derm, Bhatia Derm, but our practice is Oak Derm. So you can get to us that way. Nice. And our website's just oakderm.com. So it's very simple. So
awesome.
Yeah.
Right on. We'll link to all of those for sure in the show notes, so people can check that out.
Yeah.
Wonderful.
So come see us.
Yeah. Come see it. Absolutely. Now, Dr. Bhatia, the question that we always like wrapping up with for all of our guests is, what is your definition of health?
I would say my definition of health is really, maintaining the gift that we have in our bodies, right? So, and it's so easy to take it for granted, but really, taking care of yourself is health, and that encompasses so many things. I'm a little biased towards the skin, but every aspect of your health, diet, exercise, mental wellness, so important as well. So, that's, I would say, my definition of health is really multifactorial.
I love that. Yeah, I mean, our health really is a gift, isn't it? It absolutely is. Well, Dr. Bhatia, thank you so much for joining us. This was such a fun conversation for us.
Yeah, really interesting.
Yeah, it really broke us out of kind of our niche and in our realm. This is awesome. So thank you.
It was really my pleasure, and I love listening to your niche as well. So
Awesome.
Congratulations, and thank you for doing this for people.
Absolutely.
I think
sure.
you help a lot of people this way.
Oh, thank you. Thank you. Well, for our listeners, who do you know that needs to meet with Dr. Bhatia and his staff? Who do you know that needs to hear this episode? Share it with them so they can learn more about the amazing work that he and his staff are doing. And while you're online, head on over to iTunes, leave us a rating and review. It means a world to us when you do that because it allows other people to find us easier. Thank you so much for tuning in. We always appreciate it. Have a fantastic week, and we'll talk with you all next week.